Welcome to this next video in which we are discussing tuberculosis and anti-tuberculosis drugs. So, we're currently in the process of discussing the adaptive immune response to tuberculosis. And so far we've seen that we will produce these T helper 1 cells which are targeted against fragments of antigens from the Mycobacterium tuberculosis cells, and these will go to the site of infection and will activate the macrophages that are currently host to Mycobacterium tuberculosis cells inside their phagosome to kill those Mycobacterium tuberculosis cells. So they're going to activate the killing mechanisms for those macrophages with the hope that they will then be able to actually kill the Mycobacterium tuberculosis cells. What I now want to discuss is the formation of caseating granulomas, which is one of the hallmarks of a Mycobacterium tuberculosis infection. It's the way in which the adaptive immune response actually deals with the Mycobacterium tuberculosis. And we will now finally get to understand the difference between an active tuberculosis infection and a latent tuberculosis infection. So, we need to discuss then this concept of a caseating granuloma. Okay, so firstly, what actually is a granuloma? So before we go on to caseating granuloma, let's just discuss granuloma. So a granuloma is a roughly spherical ball of immune system cells that is going to form, in the case of tuberculosis, around the sites where the tuberculosis bacterium is actually present. So remember, we have breathed in the Mycobacterium tuberculosis, and cells of Mycobacterium tuberculosis have potentially gone to multiple different sites within the lungs. At each of these sites where you've got a Mycobacterium tuberculosis infection, granulomas will form. Okay, and these are, as I say, roughly spherical nodules that can get so large that they are visible to the naked eye. So they can get, for instance, up to 1 centimeter in diameter. So let's talk through the structure of a granuloma. I'm not going to be able to give you the mechanism by which these granulomas form. The mechanism by which they form in this way isn't particularly well understood, so what I'm going to do instead is just describe to you the structure of these things and describe the motivation for what they're doing, and go on to discuss how they are how we actually develop a latent tuberculosis infection. Okay, so drawing a picture then of a granuloma, it's always a good place to start by drawing a circle. So of course all I'm going to draw is a two-dimensional cross-section of what a granuloma would look like, but hopefully this will communicate the three-dimensional structure. So we'll start from the outside and work inwards. So the peripheral portion of a granuloma is going to be made up of T helper 1 cells. So these T helper 1 cells that are going to be directed against peptide fragments of antigens of Mycobacterium tuberculosis. So I've just drawn a few of these here. So these are T helper 1 cells, and I want to stress that they're not necessarily all of the same T cell clone. They might have different T cell receptors that are targeted against different peptide fragments of antigens of Mycobacterium tuberculosis. Okay, so here are the T helper 1 cells, and I'm not going to completely fill in this layer with little pictures of cells because I haven't got the will, so I'll just colour this layer in pink, but this will be full of T helper 1 cells that are directed against peptide fragments of the antigens of Mycobacterium tuberculosis. So the periphery of a granuloma is made up by these T helper 1 cells. The centre of a granuloma is made up of macrophages, loads and loads of macrophages. So I'll draw one macrophage here, another macrophage here, another macrophage here, loads and loads of macrophages. At least as a first approximation, this is how we'll see a granuloma. The core is made up of macrophages and the outer portion is made up of T helper 1 cells. And of course, the T helper 1 cells will be giving help to the macrophages. So what's the purpose of this? Well, inside the core of the granuloma, you will have macrophages that are still grappling with the Mycobacterium tuberculosis, and these are likely to be right at the centre of the granuloma. So the macrophages in the core are going to be grappling with the Mycobacterium tuberculosis. So they'll have Mycobacterium tuberculosis cells inside their phagosome. So I might just actually attempt to draw one of these. So we'll have one here. Here's its nucleus. Here's its phagosome. And I'm trying to draw a few little Mycobacterium tuberculosis now. I'll just colour in the phagosome in red there, and it's got a horrible black smudge. But hopefully that gets the picture across. Here is a macrophage that is still struggling with Mycobacterium tuberculosis inside of it. It's struggling to kill it. Okay? The T helper 1 cells around the edge will be capable of giving help to that macrophage. If it's to come close to them, they'll be able to give it help. And if the macrophage was to be overcome by the Mycobacterium tuberculosis, then of course the Mycobacterium tuberculosis cells would then be uptaken by loads of the new macrophages here. Now, so that's the basic structure of a granuloma. The periphery is made up of T helper 1 cells. The core of the granuloma, which is this bit here, is made up by loads and loads of macrophages. Let me explain what is meant by a caseating granuloma. So a caseating granuloma is one where the absolute centre of the granuloma is made up of loads of necrotic cells. So I'll just put this here. There is a patch right in the centre of the granuloma. Unfortunately, I've put a cell right in the centre of my picture here. So I'll have to put the core of the granuloma here just off to one side. So there is a patch right in the centre of the granuloma where you've got loads of dead macrophages, and these are the macrophages that have been burst open by Mycobacterium tuberculosis cells. So they've been overcome by the Mycobacterium tuberculosis cells and they burst open. And when they die by being burst open in this way, the tissue that is left over appears like cheese, hence why we call it caseous necrosis. So this is an area of caseous necrosis. So caseous refers to cheese. So it's necrosis that looks like cheese when you look at it macroscopically. So the centre of a granuloma of tuberculosis appears like cheese, hence why they're called caseating granulomas. And it's because these cells have died by necrosis. So the cheesy portion, the caseous portion, is made up by these dying macrophages. And that process of dying by being broken up by Mycobacterium tuberculosis cells is known as caseous necrosis. So right in the centre of the granuloma then, you have the caseous necrosis occurring because the macrophages have been beaten by Mycobacterial tuberculosis cells, and then surrounding that you're going to have loads and loads of macrophages, some of which will still be grappling with Mycobacterium tuberculosis cells, others which will be standing on ready for if there is a free Mycobacterium tuberculosis cell in the extracellular fluid, they'll instantly phagocytose it, and then they'll begin the battle of trying to kill it, and they'll be able to get T helper 1 help from the periphery of the granuloma. So this is what's forming at the area where the Mycobacterium tuberculosis is present. And the idea is to try and contain the Mycobacterium tuberculosis in one area. So the idea is that this will be set up to try and contain the Mycobacterium tuberculosis within the granuloma, and hopefully it's not going to be able to spread outside of the granuloma. Now just before we move on, let me tell you about the different forms of macrophages that can actually develop inside of these caseating granulomas. So inside of caseating granulomas, special forms of macrophages can actually end up developing, which are known as epithelioid cells. Now these are massive great macrophages, even bigger than normal, so big that they start resembling epithelial cells. So epithelioid cells are cells, they're macrophages that are so big now that they actually look like epithelial cells. So remember, epithelial cells, they tend to have a really squamous form, so they tend to look like a fried egg. They have a nucleus, and then because they're extremely squamous, extremely flat, they cover a huge amount of surface area, like so. So if you're looking at a epithelial cell from above, a squamous epithelial cell, this is what it might look like. And the macrophages can become so large that actually, histologically, it looks as though you're looking down at an epithelial cell, and that's the reason that they're called epithelioid cells. So epithelioid cells, are these massive great macrophages that can develop inside granulomas. In addition, epithelioid cells can start to join together in ways that are also characteristic of epithelial cells. So if I just try and show a bit of this here, so let's say this is an epithelioid cell, and I'll stress that this is a little bit out of scale. You know, you'd have far more cells than this picture suggests in a real granuloma. Let's say this is another epithelioid cell, and the idea here is that they're starting to form junctions in between each other, and the idea is that they're forming a barrier to the spread of the Mycobacterium tuberculosis. They're forming a physical barrier to prevent the Mycobacterium tuberculosis being able to spread from the granuloma. So that's another great feature of these epithelioid cells. So these are a special type of macrophage which can develop inside granulomas, and it's not really understood how they develop, but we think it must be part of what the T helper 1 cells are doing to them. So macrophages can develop into these epithelioid cells, named because they resemble epithelial cells and because they are forming junctions in between each other, similar to the sort of junctions you'd have between epithelial cells, and the idea is that you're forming a layer to try and contain the Mycobacterium tuberculosis. That's what the formation of these granulomas is all about, trying to wall off Mycobacterium tuberculosis and prevent it from spreading any further. Another type of special cell that you can form from macrophages in granulomas are the multinucleated giant cells, and these form from a huge number of macrophages joining together. So if I try and show one of these, in fact I won't even attempt to put it on this picture because there's not enough space anymore, but I'll show it here. So you form absolutely massive great cells inside the granuloma, which are formed from loads of macrophages joining together, and therefore it's a cell with multiple nuclei. So here you go. Here is a picture of a multinucleated giant cell. So this is another characteristic cell that you can see inside of granulomas. And again, they are just a specialized type of macrophage that forms inside granulomas. Okay, so to overall summarize what we've now seen, granulomas will form at these sites where Mycobacterium tuberculosis has infected, and these consist of an outer layer of T helper 1 cells with a core of macrophages and these specialized cell types that have come from macrophages, epithelioid cells and multinucleated giant cells. Right at the core of the tuberculosis granulomas you have caseating regions where macrophages have died because mycobacterial tuberculosis cells have overcome them and they've broken free. Okay, the idea is that we're going to contain the Mycobacterium tuberculosis because the instant that it overcomes one cell and breaks free, it will then be uptaken by all of the surrounding macrophages, and the T helper 1 cells are going to scream instructions in at the macrophages and try and help them to kill the Mycobacterium tuberculosis cells. These, by the way, are the tubercles of tuberculosis. So remember, right at the beginning I said that the reason this disease is called tuberculosis is because it's tubercle bacillus. So the reason that we had the bacillus was because the Mycobacterium tuberculosis cells, when you look at them down the microscope, they have a rod-shaped appearance. The tubercles portion comes from the fact that when you actually look at the lungs of someone who's died of tuberculosis, you can see these tubercles, which are the granulomas. Okay, so these things will form, and the idea of these things is that we don't ever eradicate the Mycobacterium tuberculosis. I'm afraid even with the T helper 1 mediated adaptive immune response, you don't successfully eradicate the Mycobacterium tuberculosis. The best that you get to is that the rate of production of new Mycobacterium tuberculosis cells will equal the rate of killing, and that's when you get the infection under control. So if we can get the rate of production equal to the rate of killing, that's when we've got the Mycobacterium tuberculosis infection under control, and that's what these granulomas achieve. Okay, right. So now to go over the difference between active TB infection and a latent TB infection. So once you've got the Mycobacterium tuberculosis under control and contained within these granulomas, you then refer to the tuberculosis infection as a latent tuberculosis infection. And this will continue on for the rest of your life. You will never clear the Mycobacterium tuberculosis bacterial cells completely. So when we say that a third of the human population is infected with Mycobacterium tuberculosis, most of them will have Mycobacterial tuberculosis cells inside their body contained within these granulomas, most likely within their lungs. And these granulomas are a continual process. They have to be continually renewed. So macrophages are continually dying in order to kill Mycobacterium tuberculosis cells. The Mycobacterium tuberculosis, overall, its population is not increasing in the granulomas, but we are continuously having to sacrifice macrophages for this. So you're continuously having to bring in more macrophages into these granulomas. And the call for these macrophages to comes from the macrophages in the granuloma. So the macrophages inside the granuloma will continue to release tumor necrosis factor alpha and interleukin 1, which of course will maintain the inflammatory response, and they will continue to bring in more and more macrophages to replace the ones that are dying. Also, you have to note that T helper 1 cells will not live forever, so you're going to have to continually be producing more T helper 1 cells. So some of these macrophages within the granuloma, they're going to have to participate in the antigen presentation process. They're going to have to go off to lymph nodes and present antigens to new T cells, either naive CD4 positive T cells or memory CD4 positive T cells, and activate more adaptive immune responses to be initiated, so that we're continually getting more T helper 1 cells being produced. So we're going to have to continuously be rejuvenating this structure, bringing in more macrophages and bringing in more T helper 1 cells. And hopefully you'll now realise that there is the potential for this to go wrong if you ever become immunocompromised, because if you ever become immunocompromised, the T helper 1 cell production will slow down. But I'll talk about that now. Okay, so this is what's going to happen in most people who catch tuberculosis. It will result in a latent TB infection. So let me now just go over a little bit of terminology. So the active tuberculosis infection is when the TB isn't under control, when the rate of production of new Mycobacterium tuberculosis cells exceeds the rate at which they're killing. So when the population is increasing, that's when you've got an active TB infection. So initially, we did have an active TB infection. When we initially caught the TB, the alveolar macrophages weren't capable of getting the Mycobacterium tuberculosis population under control. The acute inflammatory response wasn't capable of getting the Mycobacterium tuberculosis population under control, and the adaptive immune response took a few days, 4 to 7 days, to get that started up. So for a while we didn't have the Mycobacterium tuberculosis under control, and we did have active TB. That would be known as a primary tuberculosis infection. So when you initially catch TB for the first time, and initially it's not under control, you haven't got a latent TB infection yet, that's known as a primary tuberculosis infection. Now, most people do not get symptoms from a primary tuberculosis infection. Often primary TB is incredibly mild. It's often asymptomatic. If you do get symptoms, it's very mild symptoms. So you might get a fever, you might get general malaise, so generally feeling unwell, not firing on full cylinders, that sort of thing, and you might get a cough. So it might just appear like a mild cold a cold or a mild flu. So it wouldn't be a major disease. You wouldn't instantly think to yourself, oh my goodness, I've got tuberculosis. You'd dismiss it as, I've got a mild cold, or a mild flu, or a cold, or something along those lines. Okay, so then what will happen if you're immunocompetent? Then your adaptive immune response will arrive before the Mycobacterium tuberculosis population has risen to an uncontrollable level, because remember, thankfully, Mycobacterium tuberculosis has that incredibly slow division, and therefore the adaptive immune response will arrive before the Mycobacterium tuberculosis population has got very big. So in the immunocompetent individual, this primary active tuberculosis will become latent tuberculosis, and you'll just get a few little granulomas forming at those initial sites where the Mycobacterium tuberculosis came into your lungs. Okay, and we'll then say that you have latent tuberculosis. So in the immunocompetent person, this is going to follow. Primary tuberculosis will go on to latent tuberculosis. Now comes the nasty bit. What happens if you are immunosuppressed? So if there's problems with the adaptive immune response, what happens? So I'm afraid primary tuberculosis goes a very different way if you are immunosuppressed. So firstly, let's just go over some of the major reasons for immunosuppression, and these are all common knowledge. So major reasons why you might have problems with the adaptive immune response. And by the way, when people talk about immunosuppression, they generally mean suppression of the adaptive immune system rather than suppression of the innate immune system mechanisms. So immunosuppression, immunosuppressant drugs are drugs that block the adaptive immune response. Anti-inflammatories are drugs that block the innate immune response. So immunosuppression really means problems with the adaptive immune response. So major reasons that you could be immunosuppressed, of course, if you are HIV positive and you have got AIDS, then that's a major reason that you could be immunosuppressed. In AIDS, you'll have much lower populations of CD4 positive T cells, and therefore you'll have huge problems initiating this T helper 1 mediated adaptive immune response. In addition, other reasons, and I'll just make a little note of these, so AIDS is one reason. Other reasons are you could actually be on immunosuppressant drugs. Let's say you have received an organ transplant, then you'll need to be on immunosuppressive agents to prevent your body from attacking the organ. So if you're on immunosuppressants, that would also produce immunosuppression, a block of the activation of the adaptive immune response. And another major reason to be aware of is if you're on anti-cancer chemotherapy. So if you're taking some of these very powerful medications for cancer, generally anti-cancer chemotherapy drugs, the way they work, at least the old ones, the way they work, the classical anti-cancer chemotherapy, I'm afraid it's a very blunt mechanism. Cancer is caused by cells dividing too fast. So the blunt old anti-cancer chemotherapy agents, they work by blocking cells dividing. They stop cellular division, and they block it usually in all cells around the body. And this is the reason that anti-cancer chemotherapy has so many horrible side effects. Now, of course, to initiate an adaptive immune response, you need cells to divide. Remember, once you've activated the initial CD4 positive T cell, either the naive CD4 positive T cell or the memory CD4 positive T cell, what does it do? Getting the piece of paper back up, it divides and divides and divides and divides. Okay, so if you block cellular division, that's not going to occur, and therefore you're not going to get adaptive immune responses working correctly. So anti-cancer chemotherapy is another major cause of immunosuppression. Okay, so all of these things could lead to immunosuppression, and if you don't have a proper adaptive immune response, then I'm afraid the Mycobacterium tuberculosis infection can just get out of control. So what can happen is you can initially get what's known as progressive pulmonary tuberculosis, and this is, as it says, the Mycobacterium tuberculosis population is just going to go up and up and up and up, and it will spread throughout the lungs. So progressive pulmonary tuberculosis, where rather than just affecting a very small site, it's going to start affecting the entire lungs. And of course, if it affects the entire lungs, you're going to get the inflammatory response occurring all over the lungs. And the inflammatory response occurring all over the lungs is not good at all. Occurring in tiny little portions of the lungs, which is what previously it was occurring in. So previously we breathed in a few Mycobacterium tuberculosis bacteria. They went to certain portions of the lung and we got the inflammatory response occurring in those portions of the lung. Okay, so it wasn't occurring in too many places. And that didn't cause a problem, but if this occurs all over the place, there's a big problem. You bring in a huge amount of inflammatory exudate, a huge amount of cells into the alveolar spaces. What's that going to do to gas exchange? It's going to hugely increase the diffusion distance for oxygen and carbon dioxide, so it can lead to huge problems with breathing. And when you get inflammation occurring in a huge amount of lung tissue, that's known as pneumonia. So progressive pulmonary tuberculosis can lead to pneumonia. Pneumonia is inflammation in the alveoli, and you wouldn't refer to what we initially had, which was inflammation in a tiny little portion of lung tissue, as pneumonia. It really needs to be a widespread inflammation in lots of the alveoli all over a large region of the lung before you would then call it pneumonia. Okay, it needs to be inflammation occurring in a large enough portion that it's actually dangerous. So progressive pulmonary tuberculosis can then cause pneumonia. In addition, what can happen is the Mycobacterium tuberculosis, if completely unchecked, if the population is going out of control, it can then end up disseminating around the body. So they can end up breaking into blood vessels or going via lymphatics into blood vessels, and then they can disseminate all around the body, and they can end up in loads of tissues. So they can go to the liver, they can go to the heart, they can go to the spleen, you name it. They can go to all of the major tissues, the brain, so they can go up to the meninges, for instance. And when you get disseminated tuberculosis, when the bacterium starts going all over the body, that's known as Milleri tuberculosis. Okay, so Milleri tuberculosis is disseminated tuberculosis, where it's gone all over the body. Now, the one that's particularly dangerous is when it goes to the meninges. So it can cause meningitis. So the tuberculosis bacterium can go up to the meninges in the brain and can then cause meningitis, so inflammation of the meninges. And why is meningitis particularly dangerous? Well, firstly, of course, it can damage the brain potentially. It could either lead to an infection of the brain, encephalitis, which would be extremely dangerous, or the inflammation in the meninges could then lead to compression of the brain, which would also be very dangerous. But another of the major dangers of meningitis is that it's very easy for pathogens that are in the meninges to end up back in the bloodstream. And the reason is that if you've got pathogens in the meninges, it's very easy for them to get into the cerebrospinal fluid, which can then drain into the bloodstream. So there's the possibility that if you get meningitis, you then get a huge amount of the bacterium in the bloodstream. Now, of course, we had bacteria in the bloodstream before. So they were coming in from the lung and disseminating all over the place, but we didn't have a huge number of them in the bloodstream previously. So we would initially refer to it as a bacteriemia. So bacteriemia refers to bacteria in the bloodstream, but it's not yet septicemia, which is much worse. So bacteriemia just means, as it says, bacteria in the bloodstream. Septicemia means a huge number of bacteria in the bloodstream, so many that it's going to cause major pathology. And the major pathology that happens when you've got septicemia is that you get bacterial cells going everywhere in the body, initiating inflammatory responses everywhere in the body, which then causes blood volume to plummet down because all the plasma fluid is going into these sites of inflammation, and that then leads to septic shock and cardiovascular failure. So septicemia can lead to septic shock. So this is the reason that meningitis is so dangerous, or one of the major reasons that meningitis is so dangerous, that if you've got a bacterial infection in the meninges, you're going to have loads of bacteria going into the cerebrospinal fluid, because of course the cerebrospinal fluid lies just underneath the arachnoid mater, which is one of the meninges. And once you've got loads of bacteria going into the cerebrospinal fluid, you're going to get loads of bacteria going into the bloodstream, because the cerebrospinal fluid drains into the bloodstream. So that can then produce septicemia, which is blood poisoning. That's the difference between bacteriemia and septicemia. Bacteriemia just means a small number of bacteria in the blood. Septicemia is blood poisoning, when you've got so many bacteria in the blood that it's actually going to lead to you dying. And the major mechanism by which septicemia kills you is that the bacteria will go all over the place in the body. You'll get them coming out of the bloodstream everywhere. You'll get the inflammatory response initiated wherever the bacteria go, and you'll get so much fluid leaving the circulatory system as part of the inflammatory exudate that blood volume collapses and you get cardiovascular failure, and that's known as septic shock. Okay, so that's why Milleri tuberculosis and meningitis is so dangerous. So I'll just write the keyword meningitis, which means inflammation of the meninges. Okay, right. So that's what happens in your primary TB infection if you are immunosuppressed. Now what I want to talk about is secondary tuberculosis. So what happens in a secondary TB infection? So, in a secondary TB infection, what occurs is you get your primary TB infection. So we've got a person who is immunocompetent initially. They get their primary TB infection, and this is controlled by their adaptive immune response, and they get their latent TB infection. So they've got a few granulomas in their lungs, and there's mycobacterial tuberculosis cells in these granulomas, but it's under control. The Mycobacterium tuberculosis population is not increasing, and it's not escaping from the granulomas. It's completely under control. What can then happen is years later you can get reactivation of the tuberculosis. And what is thought to happen here is, as you get older, or potentially because you later develop AIDS, or you later take an immunosuppressant, or you later have to take anti-cancer chemotherapy, so later in your life, for some reason, your adaptive immune response gets weaker, and that means that the tuberculosis, which was being controlled by the chronic renewal of these granulomas, the immune response fails now, so you might stop producing more T helper 1 cells. So if for some reason your adaptive immune response becomes weaker with time, then T helper 1 cells will stop being produced, and then the granuloma will no longer be able to control the Mycobacterium tuberculosis, because without the T helper 1 cells, the macrophages can't actually keep on top of the Mycobacterium tuberculosis cells. They have to have the activation by the T helper 1 cells. And remember, T helper 1 cells do not live forever. They have a lifespan of generally about a week. So if for some reason the adaptive immune response fails, you stop creating new T helper 1 cells, then the granuloma will fail. And then the Mycobacterium tuberculosis can start dominating again, winning. And then the same story as is over here will occur. You'll get progressive pulmonary tuberculosis, where it's spreading throughout the lungs, and also potentially Milleri tuberculosis, where it's disseminating in the bloodstream to other organs. And a particularly dangerous place for it to go is the meninges, because there it can divide and throw bacteria into the cerebrospinal fluid, which will then go into the bloodstream, causing septicemia and septic shock and death. Okay, so that then concludes the discussion of tuberculosis. We'll have a break here, and in the next video we will discuss the anti-tuberculosis drugs. But just before we do have a break, let me just finally stress what it would be considered an active TB infection and what would be considered a latent TB infection, because I want to really make sure, I promised right at the start that this would be clear by the end of the video, so I want to make sure it absolutely is. So an active TB infection is where the TB is winning, where its population is gradually increasing. A latent TB infection is where the population is under control, it's walled off within these granulomas, and it's not increasing. Okay, so In immunocompetent people, a primary TB infection, which is initially an active TB infection, should become a latent tuberculosis infection. In immunocompromised people, you will never get that control, and instead the infection will always be an active TB infection. In secondary tuberculosis infection, that's where the adaptive immune system for some reason has become weaker, and you're no longer able to maintain the tuberculosis infection as a latent TB infection, and it's now reactivating, it's becoming an active TB infection once again. Okay, so I hope that's now clear. We'll do the anti-tuberculosis drugs in the next video.